In this series of lectures here, we'll be investigating the mitral valve, its anatomy, and how it's actually involved with regurgitation. This particular lecture here will identify the components of the mitral valve and its supporting structures. We'll work through the standard view as a sonographer that we use to investigate for mitral regurgitation, and next we'll also explore how transesophageal echo will be used to assess the regurgitant valve. The mitral valve has an annulus that's slightly elliptical in shape, and viewed side on, the valve actually appears saddle-shaped. The posterior leaflet has three scallops or sails, which are the lateral, middle, and medial. These are also known as P1, P2, and P3. The anterior leaflet does not have determinative markers, but is also roughly aligned as A1, A2, A3. Note in this particular view here, we have a surgeon's orientation, where the anterolateral edge is shown to the left and the medial to the right of the image. The subvalvular apparatus plays an important role in valve function. There are posteromedial and anterolateral papillae muscles, and these form a tethering point for the chordae tendineae, which then support the mitral valve. Unsurprisingly, problems with the chordae and the papillae muscles will lead to valvular regurgitation. There are a few types of chordae, which may be primary chordae that run from papillae muscle to the leaflet tips, secondary chordae, which bifurcate from the original primary ones, and then there's also commissural chordae, which reach to both the anterior and posterior leaflets, and finally strut chordae that arise from the ventricular wall and insert directly into the leaflet. Here we have the standard parasternal long axis view. We use papillae muscles as markers for obtaining the true LV cavity diameter. In the ideal view, the true diameter is obtained by aligning your probe between the two papillae muscles. When the leaflets close, the coaptation may be followed by a slow second motion of both leaflets moving towards the annulus, but actually beyond the annulus. This is called systolic bowing of the leaflets. Importantly, the sonographer must pan through the leaflets by tilting anterior and posteriorly to identify all three segments. Color is applied and the same tilting performed to identify the origin and direction of regurgitant lesions. And in this view here, we have a parasternal long axis view, left ventricle mitral valve. And importantly here, we've actually got a very bright here in the center part of the valve. And what we've actually got is a mitral valve clip. So a way of actually restoring function of the valve where it's competent, they place a clip mid-portion that grabs the anterior and posterior leaflets and basically holds them together. The clip is made of metal, so it comes up as this bright area on the screen. From the parasternal short axis view, the anterior and posterior leaflets are seen with a fish-like view in diastole. The commissure is not entirely horizontal and lies slightly oblique, lying at around about the 2 o'clock and 8 o'clock position. This view is best obtained by tilting inferiorly from the aortic valve to obtain the mitral valve in short axis. The sonographer then must pan through the valve by tilting anteriorly into the LA and posteriorly down to see the chordae and the papillae muscles. And again, this motion is applied with color having the same sweeping motion to identify origin and direction of regurgitation. From our parasternal long axis shot earlier, this is now a parasternal short axis shot of the mitral valve. Again, we can see this bright area here where the actual clip holds the anterior leaflet and the posterior leaflets together. And even though there is the clip, there's still some resulting mitral regurgitation. Here we have the apical four-chamber view, where the anterior leaflet is seen to the left and the posterior leaflet is seen on the right of the image. The anterolateral papillae muscle should be seen as this view attains the anterolateral LV wall. It's important to note this is an oblique cut through the valve. It does not run along the leaflet commissure. And this is a standard view for measuring inflow profiles, pulse wave for diastolic function, and stroke volume measurements, and continuous wave for forward flow intensity and stenosis evaluation. And here we have a typical apical 4-chamber view. So we also assess the mitral valve from the apical 2-chamber view, which is called the true commissure view. Both pupillary muscles, the anterolateral and the posteromedial, can be seen. The mitral valve takes a tri-leaflet appearance. We can observe the medial portion of the posterior leaflet, then the mid portion of the anterior leaflet, then the lateral portion of the posterior leaflet. This presentation is due to the crescenteric shape of the commissure, which is the posterior leaflet dominating the majority part of the annular circumference. The anterolateral pupillary muscle is removed when we go to the apical 2-chamber alternative view. By rotating counterclockwise a little bit further, we move away from the anterolateral wall to the true anterior wall. The anterior leaflet is seen on the right of the image and the posterior leaflet to the left. And again, we've now got an oblique view through the leaflet commissure. And here we have an example. So we can see both pupillary muscles associated with the true commissure view. In this instance here, we'd see the medial portion of the posterior leaflet, the middle portion of the anterior leaflet, and the lateral portion of the posterior leaflet again. Then by rotating counterclockwise, we obtain the true inferior wall and the true anterior wall. Apical long axis, of course, is another view that we'd like to use to investigate the mitral valve. It represents the peristernal long axis view with everything rotated 90 degrees. So instead of the heart being horizontal on the screen, it's presented a little more vertical. And here we have a typical apical long axis view where you can see the mitral valve quite clearly, posterior leaflets and anterior leaflet there. The investigation continues where we move to the subcostal window, where we can get a subcostal long axis view of the heart, which is very similar to an apical 4-chamber view, but again rotated roughly about 90 degrees. Instead of the heart being vertical, is now a little bit more horizontal on screen. We can also get a subcostal short axis view of the mitral valve, similar to a peristernal short axis, but again with a view tilted across. This view may be useful if there's significant anterior annular calcification prevents the viewing from this particular window. Transesophageal echo is widely used because of its high frequency, allowing for greater spatial resolution, and is optimal for the investigation of abscesses, infective endocarditis, cardiac source of emboli, and work up towards valve replacement. The anterior leaflet is seen at the bottom of the screen because basically we're viewing from the inside out. Views that mirror the apical lung axis 2 and 4 are obtained. Transesophageal offers very good detail when viewing the apical aspect of the valve. If there is significant calcification, the ventricular aspect of the valve may be difficult to actually visualize. Moving the probe transesophageal, the user can visualize the mitral valve from a long axis and short axis view. Transesophageal imaging is limited by the placement of the probe in the esophagus and contact with its wall. This is different to transthoracic echo where the entire chest can be utilized. So why do we actually use TOE? Because the transesophageal is useful in confirming transthoracic findings, and it provides high imaging, specifically when it comes to valve detail. The study provides another opportunity to evaluate mitral valve hemodynamics and provide further confidence in calling the diagnosis. The studies are often used to determine whether a valve is suitable for valvuloplasty or repair as alternatives to replacement. We can assess the severity of mitral regurgitation, viewing from the atrial aspect of the valve, which is useful if there's significant annular calcification or prosthetic valves which distort the image from a transthoracic approach. This modality is best used to rule out thrombus in the LA and the LV, particularly in the left atrial appendage, when there's coexisting atrial fibrillation. And the right ventricular systolic pressure can be measured, which in turn evaluates the pulmonary artery systolic pressure. A competent study will also assess for any coexisting aortic tricuspid valvular disease, not just the mitral disease, which is our focus. And here we have an example from a transesophageal window. We can see our valve, and here with the colour applied, we can also see a little bit of regurgitation. The mitral valve may have regurgitation arise from mechanisms which involve the valve structure itself or the supporting apparatus. Both are interrogated easily by transthoracic and transesophageal echo. There are typical views a sonographer will utilise to assess the valve and its supporting apparatus. The greater the complement of images in a study, the more accurate the diagnostic calling. A good sonographer will always go above the standard imaging protocol to investigate mitral regurgitation by qualitative and quantitative investigation and again obtain a more accurate and diagnostic call.